patient, again another debate. So again, it is a tussle or fight between surgeons and radiation oncologists. So this time, the motion for the debate is the radiotherapy with androgen deprivation therapy is an equally effective treatment compared to surgery for management of low and intermediate risk prostate cancer. So again, the same thing, whether these patients need surgery or not. So this time, for the motion, we have the chairperson. We have the chairperson, Dr. Tidibesh Mondol, Dr. Litan Nahabishas, and Dr. Siddharth Bosu. I'd like to invite all of you to come over to the podium and take a chair, please. Dr. Tidibesh Mondol and Dr. Siddharth Bosu? Not there. Litanda, you take over. So I'd like to hand over to Dr. Litan Nahabishas, and he will moderate the session.
So now we have for the motion Tanmay already mentioned the topic. For the motion, Dr. Indranil Mallick. I request Dr. Mallick to come to the stage and take the debate on.
Good afternoon. This is probably the 8th or 9th time that I'm debating on this topic or an iteration of this topic. Is radiotherapy equally effective as compared to surgery in low and intermediate risk prostate cancer? But why are we even asking this question? Is it because it's an unanswered question? No, it's very well answered. We're asking this question because many localized prostate cancer patients worldwide who meet urologists for a new diagnosis of prostate cancer are only offered prostatectomies. That is why we have to prove ourselves over and over and over again. What is low and intermediate risk prostate cancer? I don't have to explain this to you, it's there on the table. And what are the treatment options? For low risk patients, you may not have to treat them at all. You can do active surveillance, or if they want to choose a treatment, you can offer radical prostatectomy or radiotherapy alone. For intermediate risk patients, it's a choice between radical prostatectomy and radiotherapy with or without androgen deprivation therapy. For favorable intermediate risk patients, ADT can be avoided. For unfavorable risk, ADT is the standard. So these are well established. It's been established for decades and decades that patients with low and intermediate risk usually will meet both parties, both the surgeon and the radiation oncologist. I'm fortunate to work in a hospital where this happens, but it seems that it's not standard outside institutions. Now, what should the choice be based on? Of course, it's not just disease control or survival. It needs to be based on toxicities, patient-reported outcomes. It needs to be based on the convenience of the treatment, on the cost, and of course, on salvage options. Now, let's take these topics one by one. The most important topic is the disease control and survival with radiotherapy equivalent to surgery? That is the most important question. But when we pose it to surgeons, when we discuss it in debates, surgeons love showing biased retrospective analyses published by other surgeons, where there is a case selection in favor of prostatectomy. The younger, fitter individual with smaller prostate sizes, less extensive disease, younger in age, less comorbidities, gets selected for surgery, and therefore they show that they seem to have better outcomes. So beware, a lot of that is going to be shown today. But we don't have to get confused. There is a large randomized control trial. What we don't have in bladder, we have in prostate. The PROTECT trial has 10-year outcomes, nearly 1,600 individuals randomized to active surveillance, was radiotherapy or surgery. These are predominantly low-risk patients, but a fourth of them were intermediate risk, and the prostate cancer-specific mortality was identical with surgery, radiation, and active surveillance. And the freedom from disease progression, of course, patients with active surveillance had more disease progression, but between surgery and radiotherapy, there was really no difference. So this question, at least in the low-risk setting, is very well answered. Why are we debating? Now let's say that, okay, low-risk patients, we've moved on with low risk. We know that active surveillance is probably the standard. What is the issue with intermediate risk disease? Now, to set a benchmark, when we say that radiation is just as good as surgery, what is the result with surgery? And when we talk about surgery, what kind of surgery are we talking about? Now, we know that most of the neurosurgeons would prefer to do a robot-assisted radical prostatectomy. And which is the biggest, most established institution for robot-assisted radical prostatectomy? That's the Vattikuti Institute. And they have very generously published their results of 4,800 of their patients who about 50% low risk, 50% intermediate risk. That's perfect for this debate. And unfortunately, their paper does not mention how many of them had adjuvant therapies, for example. But their 5-year biochemical recurrence-free survival is 85%. Now, outside of the PROTECT trial, which is a randomized control trial which showed that, radiotherapy is just as good as surgery, which is the point of the debate, let us compare this result from the best institute on robotic radical prostatectomy with data from radiotherapy, large radiotherapy trials in low and intermediate risk disease. So these are 3 such trials. The first trial is the CHIP trial. 3,200 patients, about 3/4 of them intermediate risk, treated with moderate hypofractionation. What is the biochemical recurrence-free survival? 90.6%. The next is the PROPHET trial, only intermediate risk disease. Again, 60 grain, 20 fractions. What is the 5-year biochemical recurrence-free survival? 85%. Finally, the latest trial, the PACE-B trial, which compared moderate hypofractionation to extreme hypofractionation, just 5 days of treatment, 90% favorable intermediate risk patients and 10% low risk patients, just 5 days of treatment. What is the 5-year biochemical recurrence-free survival? 95%. With modern radiotherapy, there is absolutely no question. The results of radiotherapy with or without short-term ADT is similar to, if not better than, the results of the best institute for robotic radical prostatectomy. Let's move on. Are the toxicities of radiotherapy and ADT more than prostatectomy? We have data from the PROTECT trial patient-reported outcomes. Prostatectomy has much worse long-term incontinence. Prostatectomy has much worse long-term erectile dysfunction. And yes, radiotherapy has worse long-term rectal bleeding. So if you're looking at what the patients want, I think they love a diaper sale, don't they? So apart from patients who want to join and rush for a diaper sale, radiotherapy has a big advantage. Is radiotherapy cost effective compared to prostatectomy? I can vouch that radiotherapy costs are approximately 50% of the RARP costs in most institutions in India. How does radiotherapy compare to surgery in terms of time and disruption of lifestyle? SBRT is the new standard, isn't it? So just 5 treatments, 5 visits to the hospital with a biochemical recurrence-free survival of 95% in intermediate risk prostate cancer. So, with radical prostatectomy, you get surgery, 4 to 7 days of hospital admission, diaper use for at least a few weeks or more. With radiotherapy, just 5 short hospital visits. No diapers, lead a normal life, go and party in the evening. Oh, but what about salvage? That's the new favorite for the neurosurgeons. We can't surgically salvage after radiotherapy failures. So let's look at the reality. All radiotherapy patients, about 5 to 20% of them will fail. How many patients fail locally only? Less than 10%. And what are the options for them? There are 3 options. You can do surgical salvage. You can very well, in selected patients, do re-radiation with brachytherapy or EBRT, or you can give intermittent androgen deprivation. So does it really matter a lot if you can't do surgery in them? We've got other options. Salvage is not a big deal. Whereas salvage RT is much more commonly required after radical prostatectomy. If you're looking at standard adjuvant criteria, then at least a third of patients who are initially considered to be organ confined, no extracapsular extension, after their pathology turn out to be T3 patients. About several of them in the best institutes turn out to have margin positivity. And so whether you're doing early salvage radiotherapy or adjuvant radiotherapy, you will need it, not in less than 10%, but 10 to 30% of patients. So it's the other way around that is more important. So therefore, compared to surgery, radiotherapy is non-interventional, bloodless, painless, padless, less time-consuming, less expensive, and equally, if not more effective, treatment of localized prostate cancer. And it's really, really time to stop debating on this old topic and ask the real question. Is there a role of prostatectomy in prostate cancer anymore? Thank you very much.
That's nice presentation of the arguments by Dr. Indranil. But I think as chairman, I shall not be biased, and I shall give the equal opportunity to the uro-oncologist, Dr. R. Srivathsan, to present his arguments.
So I'm going to have a tough job, isn't it? Right. So first is to speak after Dr. Indranil. That itself by itself is a tough job, and to argue against radiation in a setting of a radiation conference is again tougher as well. Anyways, I'll try my best, and also to all my fraternity, I'll have to defend themselves. So Right, so the topic that was given is radiotherapy with ADT, very cleverly labeled like not superior, but it's equally effective treatment. So already we are at a plateau where is not above surgery, it's probably equivalent to surgery. So let's clarify that. And compared to surgery, so that's where I'm going to talk about. And the setting of it, it's not high-risk prostate cancer, but it is low and intermediate-risk prostate cancer. Right, so I'm going to speak against the motion. So you've all come for this huge titan clash, but sadly what you're going to receive is nothing but a subtle salsa, because this salsa has been going on for years together. And I don't think at the end of this debate are we going to have any proper solution to it. But okay, anyways, let's go for the salsa. So why are we having this debate? Does actually like Dr. Indranil said, that actually low-risk prostate cancer actually need treatment? If you are going to really follow Professor Hamdi, Hamdi says don't do anything. So that's what is the result of that study. Is there a direct head-on comparison, or are we going to get a direct head-on comparison in the near future? Can you actually say is one treatment better than another? Probably you can stay at equivalence. What does the guideline say? Has the surgery improved over the years, just like the radiotherapy, for us to tell that the surgery is good enough? And are we ever going to conclude this debate with an answer? So let's go on to that. So why this debate? Why have we not done an RCT? Just like the argument beforehand in the bladder cancer, I don't think there is ever going to be an RCT comparing, because the patient is going to want to choose. We always assume a cause and an effect relationship between survival difference and treatment. Never going to happen. The claim of high quality data, as you all know, data can be adjusted. You pick up 2 sentences from a paper and put it on a debate and you say that that's my argument. So that's never going to work out. Now, Dr. Indranil did say that there has been a lot of biases by the urological surgeons to say that prostatectomy is better than radiation. But if you actually go through all these papers, they have done their best to remove all the biases. If you take the propensity score matching, you've done the Newcastle-Ottawa scale method of removing the bias. So all has been attempted. There are several limitations with regards to the inclusion criteria, the patient age, the selection criteria per se as well. Also, don't forget the variables. Dr. Indranil quoted the institution of Vattikuti. So Vattikuti is a registry. So we have like hundreds of surgeons putting in that data. Now the quality of the surgeons, the whatever the methodology, the fellow doing the surgery, there are so many variables which cannot be accounted for. The extent of lymphadenectomy, the type of radiation that is delivered as per your listing, the technique, the dose, they were not at all consistent in any of the comparison papers for us to actually say they are equivalent or not. They could not secure the recommended combination of ADT. Even in a radiation paper, there was some lot of inconsistency in the ADT that was followed, whether it's 12 months, 18 months, 32, 36 months, and so forth. And finally, as I said, whether a preoperative ADT was given and what was the entire course of ADT, and so many factors were missing of all these papers. So this is never going to happen. So are we going to stick to saying which is the best or the better treatment? I would restrict myself from doing that. Probably equivalency, that is what I am fighting to see whether it is an equivalent or a non-equivalent treatment. Do we have evidence to suggest surgery is better? Let's go through the data in the next few slides. Personalized treatment is what we are looking at finally. I think the patient has now gotten the choice to choose which treatment they will go for. The first question any patient who walks into my OPD asks me is, will the cancer be out of me, out of my body? And I think as a surgeon, I can assure that patient that the cancer organ will be removed from his body. Factors to be added to the risk stratification. The family factors, the patient factors, especially nowadays, we are going to have the molecular factors, which is to decide the risk stratification and not the old risk stratification of NCCN. So I think Dr. Indranil has already gone through all this, so I'm going to skip that. Now the complication comes most probably not in the low risk pattern, but in the intermediate with the addition of favorable intermediate and unfavorable intermediate is what is going to muddle the entire picture. So we all know the NCCN guidelines. Again, there is no clarity. Whatever it is, you can do either ways. So I'm not going to go into this because it has no data as to it. So what does actually NCCN say with regards to radical prostatectomy? It says it's a very appropriate treatment for any patient with clinically localized prostate cancer, which can be completely excised, especially if the life expectancy of the patient is more than 10 years or not. So high volume surgeons in high volume centers, that's the most important line in the entire thing. Blood loss was substantial in RP, but nowadays we don't have that much blood loss. Continence, sexual function, everything is becoming better and better with our experience with the prostatectomy. Right. So Dr. Indranil spoke about the outcomes. So here are the outcomes according to us. So this is one of the, including Hamdi's paper, where you have almost cancer specific survival up to 95 to 99% with surgery as well. Especially, these are all the low risk and the intermediate which we are arguing about. So we do have a very good outcome at the end of CSS. So as the surgery improved, definitely yes, we have a lot of shiny new robots coming up, and as we had the argument before, definitely our surgery as well as the, not when compared to the open era, we have definitely improved a lot. There is better visualization, lesser blood loss, better suturing techniques, and obviously better incontinence rate. Sadly, our patients do not run to the shop or the dealer to buy the pads for a very long time at least. Right, so what are the complications rate currently? You can see that the complication rate have dipped from the open era from 5% to almost less than 1%, which is fair enough for any, and I'm talking about Clavien Dindo around 1 and 2, which is like very basic minor side effects. And once we have started following the ERAS protocol, our occupancy rate, our LOS rate, everything has come down a lot. We hardly have the patient staying for more than 24 to 48 hours. I understand that, radiation, you don't even have to get admitted, but even if you're going to hypofractionate to less than 5, it's still a visit to the hospital of more than 5 days. So we do follow this thing. Now, what is the main advantage of surgery? We give you a definitive histopathological diagnosis and staging at the end of the surgery. Can you promise me that you can do that? So the organ is out, you do this thing. Any surgeon who has done the proper surgery can actually say, yes, we have done a good job, the disease is out, we have surgical margin positive, no positive margin is there, so you're cured of the cancer. But can you declare that at the end of the completion of the radiation that the patient has been completely cured? So it takes time. You need to follow up the entire 2 to 5 years for you to actually declare that he is cancer-free or not. Adequate assessment of the lymph nodes. Definitely, imaging is good enough these days, but you do have a histopathological examination of the lymph nodes to tell us whether actually the patient has lymph node involvement or not. And in many a study, it has been proved that up to 44% can be downgraded at the end. As many as can they get upgraded, they can get downgraded as well. The most important, the improved PSA kinetic sensitivity. When I follow up a patient post radical prostatectomy, it's very easy for me to follow up the patient with the PSA because there's not going to be ups and downs. I know it has to be less than 0.01 or something like that. So it's easy for me to follow up the patient as well. It is early detection of recurrence. For me to send for the radiation, I know when I have to send the patient, so it makes my lives easier. It permits analysis of PSA kinetics and individualizes the salvage treatment as well. Now, is there any head-on-head comparison? As I already told, there is not many, but there are meta-analysis, and obviously all meta-analysis are up for biases. So these are the entire number of papers which are head-on-head comparisons. These are all retrospective as well. And you can even see Professor Amdi's paper in this as well. So Dr. Indranil raised the question of all these papers are biased because of obviously a lot of factors, but they have done the Newcastle Ottawa scale for risk of bias assessment, and they have found that adequate bias has been ruled out in order for us to evaluate the paper. So what does the paper say? Patients treated with radiotherapy experienced an increased risk of overall mortality compared with those treated with radical prostatectomy. Patient treated with radiotherapy has an increased risk of prostate cancer specific mortality compared with those treated with surgery. You see it on the graph on the forest plot on the left as well. So I also quote this paper where they compared the various studies for overall survival, cancer specific survival, and the biochemical free survival. And these are the papers, and you can still see the hazard ratio as well as the odds ratio in the next thing. All this actually supported the radical prostatectomy on the as an outcome based thing. Now, this is basically, as Dr. Raghavan said, Sweden is one where you have all the data, and prostate cancer death after radiotherapy or radical prostatectomy, and this is a nationwide population-based observational study. It showed us that most men with low and intermediate risk cancer, and I quote dictum, received radical prostatectomy, and the relative risk of prostate cancer death was somewhat lower after RP than after RT in these men. So we all know, at least this is what I tell my patients for the disadvantages of EBRT, but let's not go into that. Now, sir also quoted that the GI toxicity is slightly more than the GU toxicity, but yes, grade 2 toxicity is quite reported with this thing, and I come from the proton center where the toxicity is supposed to be less, but still you do get it. It's not like you cannot this thing. And this gives me a heart attack, the PSA kinetics after radiation. I mean, this ups and downs goes with my heartbeat as well, so I better avoid that, I would say. Now, this is something which has come up recently, and Dr. Ashish Kamath also quoted this. EBRT increases the risk of bladder cancer when compared to radical prostatectomy patients affected by prostate cancer. And this was a population-based study, and you see that the incidence of pelvic cancer is way up post-radiation after a leeway period. So 2% of the prostate cancer patient developed a secondary primary pelvic cancer. Half of them are mostly a bladder cancer or a rectal cancer, and most of them were at an increased risk of developing pelvic cancer, especially bladder cancer, when compared with patients treated with radical prostatectomy. Now, these were all multivariable competing risk analysis compared studies, so we can be this thing. So the risk for second primary bladder cancer increases by 72% at the end of 5 years. Now, I'm not going to, for the lack of time, I will skip the ADT. Everybody knows ADT is not so good. We would like to avoid it. And in probably a higher risk intermediate cancer, you are going to prescribe ADT along with radiation as well. But do we give ADT regularly after radical prostatectomy? This is a Canadian study which inquired from the Canadian surgeons, and it was found out that vast majority of the Canadian prostate surgeons do not offer adjuvant ADT following prostatectomy in patients without metastasis, and that is the same thing we follow here as well. Now, coming to the quality of life, and this is a study which is very difficult to interpret. If you ask a patient who has underwent radical prostatectomy if you would have chosen the other one, they will always say yes. If you ask the patient in a radiation cohort, if you have selected a radical prostatectomy, they would say yes. So it's always greener on the other side. It's very difficult to interpret a subjective study where the patient, after he has undergone a therapy, will you ask if you are happy with it? Most of the time they may say no. So are guidelines the final word? I mean, we cannot be dogmatic about it. We need to, flex the guidelines according to the patient preference as well. And finally, for my final slide, I don't think I will be able to decide what is the best treatment. Either you leave it to AI or you leave it to the patient. Thank you.
Thank you, Dr. Srivathsan. Now, Indranil, do you find any point to rebut? I think his last the slides he showed on the later part in the meta-analysis results.
I don't think we have a major point of rebuttal. I think we both agree on the point that both modalities are very good treatments of low and intermediate risk prostate cancer. I think that patients should get the choice between choosing based on their own preferences. And as I said, that I belong to an institution where the patients do get that choice. And patients who would prefer surgery undergo surgery. Patients who would prefer a non-surgical approach will undergo radiotherapy. In regard to the meta-analysis and the second cancers, etc., I think that the absolute risk of second cancers following radiotherapy is quite low because these are elderly patients and second cancers generally arise about 10-15 years after the treatment. So second cancer absolute risks are really low, and I don't think that should be the decision-making point. I think that these are individual choices that patients make, and I hope that Dr. Srivathsan agrees with me.
Just one line. Do you have?
I think all of us who work in a multidisciplinary institutions will give the option to the patient. We give the advantages of therapy, the disadvantages of therapy, and it's finally the patient's choice. And I think it should be in patient's hands, not in our hands for us, because he is going to undergo the therapy as well as the side effects regarding the therapy. So he has to take the decision and not us.
So thank you for the discussion. The debate has been very lively, and both sides were very lucid. Very good presentation, very good arguments, and we should give a clap to both the speakers. Thank you very much.
May I request Dr. Ellen Biswas sir to hand over a memento to our debater, Dr. Indranil Mallick sir first, and Dr. R. Srivathsan. Dr. R. Srivathsan.